So welcome to the first webinar of 2020. Tonight we're off to a flying start with James Hayes, our medical imaging educator, before he flies off to Dublin in the morning. So originally from Dublin, Ireland, he completed his undergraduate degree in medical imaging before touring around and coming to beautiful New Zealand. Since this time, he has worked in medical imaging for a number of years while completing a variety of postgrad papers. Now he resides as a full-time medical imaging educator at Ara Institute of Canterbury in Christchurch. Tonight's webinar will focus on opportunities to sharpen up your image interpretation skills with both adult and pediatric examples. And as I said, just feel free to use the chat to say where you're from. You can also use the question and answer function, and we'll keep our questions to the end for James. And I shall now hand you over to James. Thank you.
Thank you, Catherine. Look, hello everyone. I can't hear you at the moment, so I think all questions are going to go to Catherine and then over to me. But I always love those introductions because we write them ourselves. I don't know if you know that. So I'd employ me basically based on what I've just said. But sadly, normally when I go for a job, that someone else is writing my CV for me. So. Yeah, basically I've worked in medical imaging for the guts of about 20 years, and I'd like to share some of that knowledge with you because I understand that you are now, well, this is sold as an intermediate class. So for people who have a decent amount of practical experience looking at radiographs, but maybe not to a level that would put them in the radiology chair. Now, I showed these images or these slides to someone the other day, and one of the pieces of feedback I got was that my name was a bit faint on the opening slide. And I said, yeah, there's a reason for that. I need you to be able to sit close enough to the screen to be able to read my name, because that's the thing, right? Now, when I was teaching a number of years ago, it was much easier to say the following sentence. I used to be able to say that radiographs are made up of many shades of grey, but in the last decade, that became lots of sniggering and stuff like that because of the movies 50 Shades of Grey. So I had to sort of remove that because, you know, I was teaching mainly 18-year-old females, and I kind of felt a bit seedy, to be honest with you. But that is the whole thing. If you can't see my name, change the resolution on your screen or sit closer or put your glasses on or something. Right. So there's a list of 4 things I'm going to show you here. I'm going to mainly concentrate on the first one, and then I'll touch briefly on number 2, go into number 3 in a little bit more detail, and touch on number 4. Mainly because that's what you're going to see. And if I was to say what you're going to see in percentage-wise, and bearing in mind all statistics are made up, or at least 64% of them are, I would say you normally see in radiographs 75% fractures, 10% abnormalities which aren't fractures, and 5% osteomyelitis and degenerative joint. Oh, depending on your population, you might see a lot more degenerative joint conditions. Sorry. I'll have to revise those made-up statistics, but we'll show what they look like. So, there's a rule of 2, right? We do 2 of everything. We do an AP and a lateral, or a PA and a lateral. We'll go into what the AP and the PA mean later on, and so some of this will be over-explaining some things to you. But what I don't want to do is to have someone now sitting there going, if he'd just said what AP meant, the rest of that talk would have been so much easier. So we're quite simple people in X-ray, okay? I know you call us much worse things, but in this situation, we'll be able to hear you. So AP just means anterior posterior, so from the back, sorry, no, from the front to the back. And then the opposite PA would mean from the back to the front, and a lateral just means from the side. Okay, so I'll go into a lot of this talk will be about radiology speak, as I call it. And the last sort of sum up is how to look at, well, because we will also be doing chest x-rays as well. is to look at a radiology report and kind of like a game of charades, just see that it's just describing exactly what you see, but we get paid per word, you see, so we add in extra things. And so again, going back to the rule of two, there's two joints usually. So we do slightly above the joint and slightly below the joint. And if you have two limbs and you're able to compare them, because that's the best sort of textbook area that you're going to be able to see. If you have the ability to look at both shoulders, which is quite unusual, you would. In fact, in some cases, a radiographer will deliberately x-ray the non-injured side in a pediatric case, for example, to see if there is joint expansion or a slight epiphyseal problem, because you just can't tell that that particular 5 or 6 year old child has actually got an abnormality, because they would look slightly different to another 5 or 6 year old child. Right, so this is the legal stuff, all right? Yeah, the first bit is, anyway, you have to check the following things. Now, it sounds silly, but when you're working on the ward, depending on how many patients you have, and especially now that all of your images are coming on the computer, someone can walk, you know, if you're looking at a chest x-ray, which is probably 90% of the images that get sent to the ward. So you've got Mr. Jones in bed 3 or something, and you're looking at his chest x-ray, blah, blah, blah. And you're like, okay, well, I'm just going to have a quick look at one of the tubes that the patients had inserted. And you turn around to do something completely different. In the meantime, one of your colleagues comes in and has a look at a very similar image, okay? So that's now on the screen, and they walk away. You haven't seen them. Now, it sounds like I'm over-explaining this, but I've done it myself, and it's not like I'm not able to make mistakes, okay? But an area where I work now is in, there's a bus that goes around New Zealand called the lithotripsy bus, and so we only look at abdomens, all right? And we only look at abdomens with kidney stones. And there's really only 2 places they can be within reason. So what happens all the time is I'll look at an image, I'll turn around to do something useful, as I say, and then someone else will take control of the computer and call up a different patient that they might be seeing in the clinic, or that might be the next patient. So I can turn around and have a look at that image, which I assume is the patient I've got on the theatre table, and of course I've made a mistake. So as tedious as it is, you always have to check the patient details. And I think I just spent 7 minutes telling you to look at the name, okay? But do it, because it solves an awful lot of problems. The date of the exam, you might sort of wonder who cares, but it does actually make a difference, especially if you've got a patient in for something like a pneumothorax, because yesterday they might not have been doing so well, and today they might have been. Now, if you work in ICU, I didn't get the list of all of your areas you work in, but if you work in ICU, it's not just the date you're going to be looking for, but it's going to be the date and time, because, you know, you guys are working, far be it from me to try and tell you what you do, but you're working in 10-minute sections sometimes with patients recovering. Side marker, right or left. You should be able to see a right or a left marker on the image. If you can't, you need to get that verified by the person who took it, because they might have done something different, unless, of course, there's a very obvious fracture on, like, or an amputation or something like that. But even still, get the person who took the image to mark it, because if this all ends up in court, and I've been involved in a few that have, luckily not me in the court, but I've had to give an opinion to this sort of thing, those right and left markers actually make a difference. The exposure, we'll talk about that. Is the whole area covered? The joint above and below, etc. Are there 2 views? If you've only been sent one, ask about the other one, and then look to see if you can see an abnormality. So we'll be looking at to see if I can show you some abnormalities now. The rest of the stuff is kind of up to you there. Check your patient details. They'll be in one of the corners. Excuse me. Just going to take a little sip of water. So in radiology, we always talk about different types of fractures. And the reason for that is so we know which fracture we're talking about and what to look for. Now, the great thing is you're often not just looking at one, okay? But we talk about displacement, angulation, shortening or elongation, and then rotation. Okay, so if that's your femur there, you have a normal one, and then you have a little avulsed piece, which is a piece pulled off, usually by a tendon, always by a tendon. Now, the next word I struggle with, comminuted, okay, which kind of means shattered. I think that's a lovely picture of it there, the schematic diagram. I've seen some terrible images of a comminuted fracture, and that just means 3 or more pieces that are smashed, okay? So most of the comminuted fractures you see will be from a car accident or a major trauma. Green stick, only available in kids, unfortunately, but you know, they're very difficult to look for because they don't really appear as a fracture. And then if I was to drop that down to the bottom middle one, the torus or the buccal fracture is another pediatric fracture, which isn't quite broken. It's just been bent. And the reason it's called a green stick or a torus is because if you take a green stick from a tree and you bend it, it can go back into its position, but it'll never have the strength again. So it's treated as a fracture quite rightly, but it doesn't actually look broken. And then you have impacted, where the broken ends are jammed into each other. And I'll talk about these separately in a minute, and I'll show you how to spot them. Oblique, it's kind of broken in a straight line, but diagonal. Segmented, it's always a very unusual fracture and difficult to fix. Spiral does exactly what it says on the tin. It goes around the bone, and these are only available in long bones. We've talked about torus, and the transverse is sometimes being hit by a car, like it's called a bumper fracture. If this was in the tibia, where it's just a straight line across the tibia from usually a direct blow. Okay, so by the numbers, 2 is a simple fracture, 3 or more is comminuted. All right. So very simple way of doing that. So the other way we talk about it is it open or compound or closed? It's kind of a silly thing to be talking to a group of medical professionals about, but you know, if you can see the bone poking out of the skin, that's a worse type of fracture than if it's not. All right, and so that's called a compound fracture or an open fracture. And then the major problem is not the fracture, but the infection risk. And they'll be going to theatre, obviously. And they'll be the main problem, like I say, you know, bones are quite easy to fix, but the infection that they will have had inside the bone and inside the wound can be very difficult to get rid of. Excuse me. So with all fractures, there's going to be a positional abnormality. And the radiologist will always describe the relationship of the distal fragment compared to the proximal fragment. Now, fractures are hard to see, kind of like my name on the first slide, okay? It's quite discreet. You've got to look carefully. But if you've got the radiology report with you and you're told what to look for or where to look, it can be a lot easier. So always think about you're looking for the distal fragment, which is moved away from the proximal fragment. Now, that's easy when there's 2. Okay, but then you take it into 3, 4, or 6, and it starts to get a little bit harder. However, when you start to get to the higher numbers, people kind of don't tell you where they are, because A, they're slightly more obvious to see, and B, there's no point. That person's going to the orthopedic theatre, and the orthopedic surgeon is going to make a jigsaw out of their broken bone and hopefully tie it all together again. So if any one of you, or some of you may have been to one of my previous talks, a couple of these images will look familiar. And the reason I'm showing them is because they're very good. Now, this is an obvious one. And the reason I like this is because there's so many bones here. Okay, so we've got a foot here, person that is presented with pain, and you've got to look along each joint space and around each cortical outline, and then look at the trabecular pattern. So we're just looking at the great toe at the moment. And then another, and you say, well, that seems to be all right, but they've come in with an awful lot of pain. So you can ignore either side a little bit. You find out where the source of the pain is, and you find out that it's in the midfoot. So then you start to look along these joint spaces here, and you say, well, it all seems fine. But there's a bit of a problem here because that little sort of hat doesn't fit on this head. Oops, sorry. Could we all please keep our phones off? You know, so joint spaces are, bone and joint alignment is very, very important. And I don't know if you remember right at the beginning, I said, if you've got other bones and joints to have a look at, compare them. Now, this one is probably the most extreme case you'll ever see. You know, but if you think about if that bone here was only shifted by a quarter or a third of the way across, it might be quite difficult to see, especially if the patient had tilted their foot a bit. So you compare it to this one, you say, well, that's not tilted, but this one is, okay? I mentioned degenerative diseases. So quite a good way of describing this type of problem is an angry looking joint. Now, hopefully that'll make sense to you. But if I was to talk about this joint space here as being quite friendly, it's nice and round and it doesn't have any sharp edges, okay? But then we go down here and it does have sharp edges. In fact, it's got this huge bit of osteophytic lipping over here. And you say, right, well, this whiteness is new bone growth to the point where it started to poke into the soft tissue. This will be badly inflamed in here, and that's what the problem is. So that's what a very arthritic toe looks like. Now, of course, you'll see that in the knee. And the reason I'm showing the foot here is, again, to show what it looks like beside another joint. So you're comparing two similar things, whereas you don't always get both knees x-rayed at the same time. Bone texture. This is slightly harder. You're looking at trabecular pattern here. The most obvious place to see trabecular pattern, I think, is in the neck of femur. So you have to trace along all these little hexagons along here. And it's kind of like you need to see a break in it, okay? So this is normal trabecular pattern, like that. And then it's nearly like, oh, I'll tell you, I had a job when I was 12 counting lettuces in boxes, all right? And sorry, I've just got to not restart my computer because that would be a disaster. And there was, I think there was 24 lettuces that were in each box. And on my first morning, I was counting them, and I thought I was quite clever because I was doing them in rows. And the owner said to me, you don't count lettuces, you see lettuces. And it never really made sense to me until I started off in radiography. And I was like, yeah, you can't possibly count the trabecular holes because there's hundreds of them, there's millions of them in all the bones. But you can kind of see where it's abnormal. And that, unfortunately, and I hate this expression, only comes with experience, okay? Can't be taught this, won't be taught this. Right, soft tissue abnormalities. So there you have a knee, a lateral knee, and I'm going to talk about some clues first, because in general, you wouldn't have, this has got horizontal beam written up here. Okay, now it's an unusual thing to write because anyone who knows what they're looking at wouldn't need to be told that, but they've written it, so that's fine. That's a good clue. And the reason that's done in a horizontal beam way rather than rolling the patient onto their side is because the patient, two reasons. The patient can't tolerate the pain of rolling onto their side, I'm going to up that. 3 reasons. 2, you might not, the patient is so badly injured, you might not want to make the injury any worse. And 3, and importantly for the radiology signs, you're looking for things like a blood fat fluid level or a lipohemoarthrosis. Okay. Now, these are the sort of the secondary radiology signs that'll show you there's a fracture there. So a lot of you may have already spotted the fracture, but if you haven't, I'll show you how you do it. Okay, so we go to the next slide. There's the fat line and the blood line. Now, if this patient was rolled on their side, you wouldn't see that. Okay, so you need to have them lying on their back. So the fat, which is lighter than blood, will separate. And if I go back up one, you'll probably be able to see it now. Okay, it's a slightly darker line there. But if you don't know to look there, it's quite hard. So hopefully this is going to help you out in a few areas. There's also a very similar one of these in the elbow. It's in exactly the same place, not obviously behind the patella, but just behind the humerus. Okay, and then once you've seen that, what's called the fat pad broken, you're like, right, well, where else can I look around? So you might give a bit more of a detailed look, and then you see the fracture down here. So it's not even that close to it, but because you've seen that radiology sign up here, you know to pay a little bit of extra attention. So I've mentioned the cortical outline, and this is a little bit tedious because you trace your eyes around the entire outline of the bone. And then you will suddenly, because if you're just looking at it, you kind of get a bit bored and you say, oh, that seems fine. The patient's in a lot of pain. Typical man. We'll give them some Panadol and send them home. But then you say, oh, well, actually, there's, you know, this sort of injury would come in from having punched a wall. And this isn't uncommon. And so you suddenly get to one of the bones and there's a crack seen in the cortical outline, and then you kind of go, all right. Now, if you wanted to go on further and you had without the red line, you could see the trabecular pattern cracked in there. And there's probably some soft tissue swelling around here as well. So there's all the radiology signs visible there. Yeah, okay. Now, I mentioned 2 views. Sadly, the question mark here isn't in a great place. It was for me, but it doesn't look like it is at the moment. So from the front, the AP, okay, patient's lying on their back, the tube is in the air, and the X-ray machine is in the air, and you think, well, it looks a little bit like a fracture. You turn them on their side, and you can definitely see that the back of the fibula has come completely separate from the front of it. Okay, so that is why you need to do 2 views. And just in case you ever forget that, if you look at the top picture here, that's William talking to his brother last month, okay? But actually, the bottom one was from the front, and he's saying, I'll see you in 3 months' time. So just remember that. Catherine, someone's popped up with a Q&A on my screen. Oh, they've gone again.
No, all it is it's just someone said hello in the wrong place. Don't worry, I'll get you if I need you. Carry on.
Lovely to meet you. Okay, and again, so I've mentioned compare 2 sides if possible. Now, you won't always get the 2 sides, like both shoulders. You'd never really do that. Unless there was a real necessary and there's a certain necessity. And this is important in pediatrics because of the growth plates and bone age. Sometimes, although we have rough guidelines for what a child will have grown to by that age, we're not quite sure. But if it's the same as the other side, we're more sure that it's normal development for that child. But in this instance, for example, in the pelvis, this woman has come in with a sore right leg. The clinical indications here would be that her right leg is slightly foreshortened and turned outwards. Okay, now that for you working in A&E will be a very common sign. A slightly shorter leg and it's turned out. Now, even though you can't see the foot here, the reason you can tell that it's turned out is if we go to the normal side to begin with, the non-pathology side, this little bump here, the lesser trochanter, it's much bigger here, okay? So remember, all of these views are just, they're 3D images based onto 2D. So you have to imagine that if you turn a bump away from the inside, so you're turning it laterally, that bump's going to get bigger. If you turn it completely inwards, it would more or less disappear, kind of like the non-pathology one. And then you say, okay, so there's no reason a radiographer, unless they couldn't be bothered, wouldn't ask the patient to sort of straighten their legs unless they had a pathology. Or the patient said no, because it hurts, and that's why I've come into hospital. So you say, well, what's the other reason that this might happen? And you look at this nice long neck of femur here, and you sort of say, well, it's a bit munted on this side. That's not an actual medical term. But you can see this jagged edge here. Now, if this was a better image, you'd be able to see a huge break along here in the trabecular pattern, okay? And this would have been a lovely one to zoom in on, because you can just about see the trabecular pattern here. I sound very excited over a few holes like Swiss cheese. And along here you can see trabecular pattern down here quite normally, and you can see trabecular pattern along here, and along here it would shift, okay? Now, Catherine and I are quite lucky because she's Scottish and I'm Irish, so we have an area in Ireland called the Giant's Causeway, and in Scotland they have something quite as similar but not as good, and it's kind of hexagonal rocks. Okay, now in old Irish and probably Scottish folklore, it was where the giants used to lay down a bridge. In fact, they're trying to do something like that at the moment. The giants used to lay down a bridge from Ireland to Scotland to go and see their friends. They're not quite sure whether that's the case, and there's other theories that it was when some of the lava cooled very quickly because of the sea rushing in, and it formed these hexagonal shapes. But if you ever see a picture of the Giant's Causeway, and I don't know what it's called, I'm afraid, in Scotland, Catherine, but you will see all of these wonderful hexagonal rocks that fit together amazingly. That is trabecular pattern. You couldn't possibly count them, but if someone moved one of them, it would look so out of place. All right? I think I've talked enough about trabecular pattern. And there you go. So, the unexpected, kind of like in every shift you do, you have no idea what's going to happen. All right? So this person has come in with a shoulder pathology. So one of the things with shoulders is the AC joint, acromioclavicular joint, is often a problem, and it can mimic like sort of general shoulder pain. So you need to include the whole clavicle. If you didn't, a shoulder x-ray would probably be about that size. Can you see my mouse, Catherine, or not? Oh, cool, because I'm pointing to a lot of stuff, and I just thought, I wondered if people thought I was going slightly crazy. So luckily, because we include the entire clavicle, you get a decent bit of the left lung or the right lung on, okay? So in that little sort of snapshot of the chest, now it's obviously only about a quarter, you can sometimes see something like an atypical mass. So you're looking at the shoulder, but you've got the information there in front of you. So scoot your eyes around. If a patient comes in and they've got a tickly cough and a sore shoulder, then really scoot your eyes around, okay? You got the information, it's a free go. Okay, so I'm not moving on to chest. I'm just checking the time because I don't want to, okay, good. I don't want to go too over because I'm sure you've got better things to do on a Wednesday. So transverse fracture, I mentioned this at the beginning, straight across like that. Okay, oblique fracture, like I said, it kind of does everything that it's called. And the reason we give them slightly different names is because they need slightly different orthopedic follow-up and also to help other people spot them. Okay, so this one would be described as not a transverse, this would be an oblique fracture in the mid shaft or something. So it's just so the next person can come along and see it quite quickly. Spiral fracture. These are quite nasty, or certainly can be, because you can leave that little bit in the middle hanging. Now, a lot of these, and I'm going to talk about this one for an extra minute, a lot of these in adults in the lower limb come from ski injuries. Okay, it's all perfectly normal because what happens is your skis stay straight down the hill, and as you accelerate, one of your feet gets slightly caught in the bindings as you are coming off, and your leg twists. You hear a funny crack, and then the next thing you know, you're in that sleeping bag being towed down the mountain by a very good skier. However, there are spiral fractures that are seen in kids. Now, this is something to be really aware of because this is a very strong red flag for child abuse and should always be reported to whoever you report stuff to. I understand tonight we've got a variety of different clinics and hospital sizes and stuff. It certainly is necessary to report a spiral fracture to your line manager. And I'll leave it at line manager because I don't know who that is. And if you are the top of that line, you need to phone CIFs over here, Child and Youth and Services and stuff like that. The only way a child can have a spiral fracture, unless they've gone skiing, and they don't get them when they go skiing very often because they're too light, is by someone twisting one of their arms or legs. Okay, so just be very aware of spiral fractures. Okay, so a sagittal fracture, I mean, if you think about the sagittal plane in the body, a sagittal fracture just means a fracture that goes up and down rather than generally from side to side, which is the most normal type. Now, when you have a new x-ray, now there's obviously a fairly nasty fracture there. It's sometimes worth going back to see what the problem was. Especially something as traumatic as this femoral fracture, because you sort of think, well, depending on what's caused this, is there underlying pathology that might be present elsewhere? And there are two things here. In the proximal femur, there's something called the beak sign, which I'm not showing here, but there is something called the beak sign, which is, there's a drug called Fosamax, which is given to a lot of people who have osteoporosis or osteopenia. And it's a wonderful drug in most of the time. The problem is when it's not wonderful, it can give you a new buildup of bone along the proximal third of your femur, and it usually happens bilaterally. And what it comes out in, it's a lateral beak about here. And when I say beak, I mean like a little canary, just like a little triangle. Okay, so you'd see it on a pelvis, and you'd see it on a femoral x-ray, and there might be in there for a completely different reason. And if you see this beak fracture, or sorry, if you see this beak sign, it's got to be brought to the attention of someone else, someone who was foolish enough not to come to this talk tonight, okay? Because in many hospitals, and there's one that is reasonably famous called the Mayo Clinic, and they are, with any visible signs of this beak, which is the new bone growth for osteoporosis, they are putting in a bilateral femoral rod. Okay, now that's a huge, it is huge operations. So That's how seriously they're taking it, because people with this new bone growth can suddenly step off a bus or something, or go down 2 or 3 flights of stairs and get a bilateral fracture of their femurs. Now, what happens to someone who's in their 70s or 80s with osteoporosis, who suddenly gets a bilateral fracture in a traumatic sense? Well, they go into bed and then they die. Okay, so it's taken reasonably serious. Well, I say reasonably seriously, sort of an understatement there. You know, bilateral femoral rotting, and it's because the long-term consequences of this are very, very serious. Okay, multi-directional. So this is the thing. So the axial plane, the coronal plane. This is sometimes called a lover's fracture, and orthopedic surgeons like to name things in a slightly quirky way. And the reason they call this a lover's fracture is because this type of fracture is usually gained from jumping out of a second floor window. Okay, so I'm not joking. This is how it got its name. So it was thought that a lot of people got this fracture when they were jumping out of a bedroom window when either the actual wife or husband came home. It's also seen in parachutists and skydivers, I think that's the same thing, and hang gliders and stuff like that. Anyone with a hard landing can get this fracture, and it's quite nasty, as you can see. There's a good example of a comminuted. I mean, what do you do with that? You open it up and you sort of, you know, K-wire as much as you can back together. The butterfly fragment, again, showing how we're quite simple people, looks slightly like a butterfly, so we'll call it that. Segmental, and all of these, you don't need to remember the names, but it's just, because you certainly won't be asked exactly what type of fracture is it. But if you hear someone's coming to the ward with a segmental fracture as opposed to a transverse fracture, you know what you're expecting. You're expecting someone in a lot more pain. Okay, so shortening, it's quite an interesting one. If it's not displaced, it's quite hard to see, because what happens is they get impacted. So what you're looking for, instead of a black line along here, if you can imagine this is continuous, you're actually looking for a white line along here. If you think all x-rays are shadows, okay? And the more stuff in the way, the whiter the shadow. So if you think about a total hip replacement, it shows up as a bright white thing in the hip, all right, in the shape of a total hip replacement. And if you think about air in the lungs, it shows up as black. So if there's a gap, it'll be black, and if there's white, it's extra stuff. So if this is compacted, that's because there's extra bone in the way. So there could be twice as much bone in the way of the radiation just for that little line. So look for white lines as well as black lines. Student radiographers love this. What does a fracture look like? Oh, it can be white or black. Like, great, thanks. Angulation, rotation. Again, you just describe what you see here. I'm speeding up a little bit, and there is an exact example of what I was talking about there. So just because I'm showing you slides now, I'm not spending a huge amount of time on them. So osteoporosis, this is often seen, and it's seen a little bit less now, partly because when I say radiographically seen a little bit less, because since the move to digital radiography, there's kind of an Instagram filter on all images that you see. So everyone kind of looks beautiful, all right? But what you actually don't get is down the bottom, that's how white it should be, all right, that bone. That's normal bone density. Now, reduced bone density will show up blacker because remember, there's less stuff there, okay? But unfortunately, the algorithms that are in the PACS computer systems will make a poorly taken image slightly better. So kind of like, that's why I call it an Instagram feature. However, someone who knows what they're looking at will reverse that, because it is slightly different if you're a radiographer or a radiologist, that you get a slight burnout in places. And they'll show you exactly this, because that shows osteoporosis as well. And then, of course, you've got a pathological fracture down the bottom. Now this, it looks awful. This is the multiple myeloma fracture. So again, a pathological fracture. Could have just had a tiny bit of trauma here. The bones are so weak. Benign lesions, there was one of them earlier when I went on about the beak sign. You know, if you go back to previous x-rays and you're looking at the fracture, there's often a bone lesion visible in that area. So you're like, oh, if only this had been picked up. And that's why you guys are part of the net that are picking up things that should never have gone out of the hospital. If you can see a bone lesion or you think it is, great, mention it. Okay, might not be, doesn't matter. No one loses because someone brings it to someone else's attention. An avulsion fracture is seen in something this country absolutely loves, netball. Okay, balls landing on the tips of the finger and pulling them back a bit, little avulsion fractures here. And in the feet, okay, from the stop-start motion of netball. Dangerous sport. My daughter won't be playing that. Stress fractures, long-distance runners. If someone comes in to the department where you're working and they're a long-distance runner and they've got sore mid-feet, you're looking for stress fractures. Very, very difficult to see because they happen over a long period of time. And what happens is the fracture is kind of healing as it's happening. So it tends to get, the bone just gets a little bit bigger and a little bit whiter on the outside. And they're just basically told to stop running. Okay, so it's kind of like having a sore foot. Yeah, you can call it a fracture if you want. Well, you should, because it is. But the treatment is the same as a painful foot. And again, here you can see these are the Peri prosthetic fractures. They're horrible things when you see them. So this has already had, this is a femur. This person has, the yellow thing is the total hip replacement, and they may have jumped over a wall or something. They shouldn't have been. The orthopedic surgeon should have said, hey, look, now that we've put this in, no more jumping over walls. But whatever they've done, they've brought in a huge impact, and the metalwork won't break, so it'll smash and splinter the bone around it. And that's getting quite hard to fix at this stage because you're already missing the joint up north. Things that mimic fractures, okay. You've got growth plates. So again, in children, and I go back to my earlier comment that fractures look angry and normal bones look happy and round. So fractures are angry and angular, and bones that are growing, they have nice round edges. Interesting. Okay, so here's another one, the corner of the foot. You've got an avulsion fracture here. Can you see the difference? Oh, sorry, I forgot you guys can't reply to me. I find this system a little bit weird. Look, this is the last x-ray of the bone I'm going to show you, and I've only added this one of the neck because it's very, very difficult to, or sorry, it's very important. There are lots of images of the spine that you'd look at if you were looking for a fracture, but this is something that you may see coming into the department. And if you can look at one cervical x-ray, this is the one to look at. So this one has a collar, so you know they've come in with a reasonable amount of trauma. You can count all the way down to T2, which is fantastic, okay? So the thing to do is you draw a line along the front, and we'll call that the anterior line. And that's the anterior of the vertebral body. And then at the back of the vertebral body, there's the posterior line. Okay, you can have a look at the spinal cord in the middle there, and then at the back, just before the end of the spinal spinous processes, you've got the spinolaminar line. Now, they should all be smooth. It sounds like I'm taking it too casually there because this is someone's neck, but you can see here they do make angles. They turn corners, but they're all very smooth, okay? It's when you get a right angle or something like that, or a step, that's a problem. All right. You won't be involved with taking this patient's hard collar off until this has been cleared by a radiologist, I would suspect. But it's very useful for you to be involved when you've had a look at these x-rays. Catherine, I'm happy to take any questions now on the bones if anyone wants.
Yep, so the only question we've got sitting at the moment is James says, "Hi James, do you have a slide for rheumatoid arthritis bone erosion, please?"
Yes, but not immediately to hand. What I can do is, can I send you something, Catherine?
Yeah, so what we can do is normally they'll get your slides off you as well, and they can be put out to those that have been on. So maybe you can just add a few extra bits if there's any questions that people.
Rheumatoid arthritis.
You asked about one of the lateral ankle, which was one of your earlier ones. Have you had a picture of that without the red line on it?
Yeah, don't worry. I thought of that at about 6:30 today. No, that's a really good question. Thank you. So, rheumatoid arthritis and lateral ankle.
And then there's Carly's asking if you have any hints for picking shoulder dislocation.
Okay. Yes. If someone asks you, always say it's an anterior shoulder dislocation, because then you'll think like you look like you know what you're talking about. Because about 90% of them are anterior. Okay, really difficult to spot which way they are unless you've had an axial shoulder, which is a patient. I don't know if you can you see me? So they've got their arm out to the side and the x-ray is coming down like this.
Yeah.
And then it'll either go forwards or backwards. But guess what? If you've got a dislocated shoulder, you won't do that when someone asks you to do it, because you're in there because you've got a dislocated shoulder. So the best way of spotting a dislocated shoulder is actually clinically, because a patient will do this. If it's their right shoulder, they'll just hug their right arm into them and they won't move. And also, if you do get an x-ray, like an AP x-ray, which is the most common, there'll be a decent gap. So it'll be lower, it'll be subluxed as well as dislocated, okay? But what I'll do is I'll add lateral ankle and dislocated shoulder to the list. And I'll just add these. There's about 100 slides. Oh no, there was 100 slides, because until the other day, I thought this was a 2-hour talk. So what I'll do is I'll add these to the slides, and then Catherine will send the first person a prize who can tell her the number of where I've added the slides. She actually won't, but I just thought I'd add that, because I'll be in Ireland when she's being harassed for a Mars bar or something like that.
No pressure.
Yeah.
And you've just got Erica as well, just asked if you've got any tips for reading x-rays while a patient is in a cast.
Yeah, get them out of the cast. Sorry, that wasn't supposed to be as rude as it may have sounded. There isn't any, because the stuff you're looking for, like the trabecular pattern, if they're in a fiberglass cast, fiberglass mimics trabecular pattern. So does the hexiglass. If they're in a plaster of Paris cast, everything's lost. So the only thing you can look for is the shape of the bone. So you know roughly what shape the bone should be, and you're following where the outline is, but you can't see the cortical outline, the white bit, because it's the same shade as the plaster. So no, it's a godlike ability if you can, and no one can. Okay, so sorry. I can try and find out from some of my colleagues or something if there's any. Well, I'll add it to the list. Okay, plaster. I'll move on to chest. Okay, so why do you do them? The chest x-ray is the most common thing, all right, in the x-ray department. And it's kind of the barometer of the the entire body. If there's something wrong with you, it's going to show up in your chest. Your lungs they won't look as inflated as they should. Your heart might be big. You might have, I mean, if you're coughing blood, that'll show up as white streaks in your chest. Basically, and this is why everyone has a chest x-ray. It's kind of like our get out of jail free card. We don't know why you're sick, so we'll give you a chest x-ray because you'll have to go down to the x-ray department and wait for 20 minutes at minimum. And then you'll have an x-ray, get your images, and by the time you come back here, that's about an hour and a half. We've cleared a bit of the waiting room at our end, and you think you've been seen, and we've got a bit of this bonus information. I'm being a little bit cynical now, but the bonus information might find out something that they had no idea about, okay? But if you're actually going in for a chest x-ray from your GP, it's because you've got a cough, or chest pain, or shortness of breath, or blood, or a fever, or unexplained weight loss. Now, some of them are getting quite serious, unexplained weight loss, for example. And then we're going to talk about physical signs here. I actually took out, and I should have taken it out of this, sorry, the nasogastric and endotracheal tubes. I took that out completely. When I said when I had 100 slides and I had to take it down to about 60 the other day. So that green thing in the middle is gone, or the lime green thing is gone. But isn't it nice to know that you can see those? Okay, and we'll talk about a pneumothorax because they can be quite hard. And I also took out the pacemaker lead. I decided you didn't need to know about anything foreign in the chest, so I should have adjusted that. I'm sorry. Okay, so if you think back to 40 minutes ago, we talked about AP and PA. We do everything in general, we tend to do everything AP except for chests, which we do PA. And if you look at this, that's your heart, okay? And the reason we want to do you PA is because your heart is nearer the detector, which means it'll show up as a decent size. If you look at this heart, it gets enlarged. Now, one of the very common things we're looking for in a chest x-ray is heart size. If you've got an AP image, we can't look at heart size. So it's one of the things we lose from that image. Okay, so in the chest, there are 5 radiographic densities. Well, there kind of is everywhere. And we go all the way from metal to air with different grays in the middle, okay? Air can be blacker than that. Depends where the air is. If it's in the lung, it's about that shade. If it's elsewhere, it can be a bit blacker. Okay. Remember I talked about the right and left markers? Don't assume the heart is on their left. It can be on the right if the patient has situs inversus or dextrocardia, but that's relatively rare, okay? But the lung pathology can push or pull the mediastinum, something like a pneumothorax or a tension pneumothorax in particular, okay? So there's a couple of scenarios where this is quite serious. And if the patient has a pneumothorax, the radiographer hasn't put a side marker on, and the patient has dextrocardia, okay? So you look at the image and you say, oh, look at that. Silly radiographer, didn't put a side marker on, but we know the heart is on the left. So they've got a left-sided pneumothorax. You go to put in your chest drain, lo and behold, you've actually punctured their only good lung, and they now have 2 deflated lungs. That's getting quite serious. All right, so always check, find the person who did it, and tell them to, if necessary, do another one. A chest x-ray has no radiation. Well, no, obviously it has some radiation, but I mean, compared to, otherwise it wouldn't be called an x-ray, compared to like the type of background radiation you're getting every day, it's virtually nil. Okay, penetration. One of the things you've got to look for on all of your images, does it look nice? Okay, now this chest x-ray doesn't look nice because all we can see is 2 things, black and white. So we can kind of see that they've got a heart and they've probably got lungs. The lungs could have been removed and we've got no idea because we can't see them. We can just see 2 black holes. The way to check a chest x-ray is that you can just about see the vertebra behind the heart. okay? And you can't really hear. You can see the vertebra up here, but you can't see it really here. So this chest x-ray is completely overexposed, okay? They've used the wrong type of exposure here, and I don't want to bore you with the details of that, but it's just not appropriate. So this needs to be rejected and say, you know, send back something useful. I am going to bore you. It's got too much milliamps and not enough kilovolts. Haha. A life of a nerd. Right lung lobes, you know where they are. They always surprise you though, because the right lower lobe is at the back. When you look at it from the side, so when you're kind of looking, when you're looking at a radiology report, these are quite useful to remember sometimes, and this is why it's great that you're going to get these images, because I certainly don't want to be reading this out now and expecting you to remember them. Otherwise, I'd have to come up with a silly mnemonic, and no one likes that. Left lower lobes and upper lobes shown there, and then the major fissure. Okay, so this is the heart size. You measure A and B, and the reason it's A and B is, and not just A, it sounds silly measuring A and B, but there is a reason for that, which we'll get into a bit later on. And then you divide it by C, and that's your cardiothoracic ratio, okay? So that comes up on a number of different things, but remember, you can only do that if the chest x-ray was taken in the PA view. So your heart will get big if you have too much fluid. If you're going into heart failure, one of the early signs of that is an enlarged heart, because your heart is trying to pump the blood around the body, and it just can't keep up. So it starts to get bigger and bigger and bigger, and then you guys know the end result there. Okay, I'm certainly not going to read this, but by all means have a look at them. What this says, and I've managed to say it in a lot of words, is that a small opacity, less than 3 centimeters in diameter, is called a solitary pulmonary nodule, but if it's bigger, it's called a mass, okay? Nice and simple, so the 3 centimeters. There's other things, it's got to be well marginated, and it can't touch the lung parenchyma, but the main thing is the size, okay? So if we get into that, you can measure it, you just measure the distance like that, and if you don't have calipers on your screen for some reason, most PACS systems have these calipers now, get a bit of paper and do it. Measure it off the screen like that. Draw little lines on the paper and then measure the lines, okay? You know, it's not going to be a mass if it's 2.9 to 3.1. You don't have to worry about that. That's all dealt with down in pathology. What you're interested in is your patient, and that's the best way to do it, okay? So something 4 centimeters is a mass, and something 2 isn't. Fluid levels. Just have a look at this picture for a second. One of them, the one on the left, I don't know if it's your left or right, because I don't know which way you've got your screen, but the one on A has what we call a meniscus, and the one on B doesn't. Now, these are too easy to look at, so we'll go into x-rays, okay, or radiographs. This one is a nice, straight, flat line. It's not nice at all. It's a horrible thing. The reason it doesn't have that meniscus is because the fluid is in an area where it's mixed with air, okay, so the air is pushing down on it. Ideally, you don't have this fluid in here, okay? This is a lung full of lovely air. And so the lung wants to push down, the air wants to push down. You can't see what I'm doing with my hands. Okay, I'm kind of going like that. The air wants to push down, so it's flattening that meniscus. Oh, I daren't adjust this camera. So it's pushing down, so it gets rid of that meniscus, okay? And now you can't see the top of my head. I think that's better. I haven't brushed my hair, okay? So that's if the flat line fluid is if it's in the lung. This one has a meniscus. Do you see that? Sorry, I keep waiting for you to answer. Okay. So this means that it's outside the lung. So I don't need to do any more probably hand movements. I look like a cheerleader who's lost her pom-poms, I'm afraid, when I teach. Okay, consolidation. It's a word we talk about all the time, or we kind of do. Okay, it just means that your lung tissue should be spongy and If you squished it in your hands, it would bounce back together. Consolidation just means it's hard. And consolidation kind of means we're not quite sure what's going on here, but we know it's not right, so keep an eye on it, okay? That's what consolidation means. Can be for a variety of different things. Now, I mentioned congestive heart failure. Wow, that'll be corrected. Put that on the list. Just goes to show you that I'm not perfect, in case you were wondering. It's when it's not able to pump sufficiently the blood to meet the body's needs, so it starts to get very big. Now, there's a whole lot of other stuff going on in here. You've got the curly B lines. These are starting to get a little bit difficult to see. But if you can imagine what stitches look like, they're very horizontal lines, okay? Those are your curly B lines there. And if you could see my name, you should be able to see them. Now, the only way you can see curly B lines is if there's lots of them. You're looking at about 5 or 6 in a row. Otherwise, it's just a particular piece of a lung marking which happens to be horizontal. One is not a curly B line. Lots of them are. You've got capitalization of the vessels, which just means that they're slightly more solid as they go up towards the head, so they get thicker and whiter as they go up. And you've got a pleural effusion, so that white line going out to the side. So do you remember I said the chest x-ray was kind of like a get out of jail free card? This has got so much information on it. But then what else are you looking at? What other stuff can you see about that patient? Okay, because when you get that image, you might get the image before you get the patient. So you got to say, well, yeah, they're in heart failure, okay, which isn't good. It's not terrible. You know, it's not the worst thing you're going to see probably that day. But you know that they've had cardiac surgery because they've had their sternum wired back together. And you know that they're well enough that they could stand up, so they're not slumped in a chair. All right, so they've got a pleural effusion and they've got a bit of heart failure, whichever way you spell it. But they're generally quite well. Okay, so these are why but you want to know about the previous cardiac surgery because that might make you look up their cardiology notes just before the patient arrives. And so this is why radiographs often have more clues on them than exactly what you're looking for. It's like if you're a colonoscopy, is it called a colonoscopy nurse or something like that? No one can answer me, so I guess I can say what I want now. You know, find a polyp. You don't just stop there. You look for another polyp and you keep on going until you reach the end, so to speak. Sorry, that amused me. Acute ARDS, acute respiratory distress syndrome. Now, this is a slightly more serious one. So you get widespread inflammation of the lungs here. So we talked about the white or the black. So immediately before this patient comes to you, you might get this image. And what can you tell? Well, they're so ill that they didn't want to take the chest wires off their lungs or off their chest. Okay, so they're doing some pacing or something like that. And although it's great to have a radiograph without these wires on, the patient isn't stable enough to take them off, so they've done it with them on. They've also missed off the top. That's not a real problem because you're not really looking at the right apice. You're looking at the general chest here. But that shows you that the patient can't stand, because any patient that can stand is level, okay? The right and left lung are level within a couple of millimeters. This one isn't. So this one's either sitting slumped to the side or they're lying on their back. Okay, so this patient is very, very unwell. The biggest problem with ARDS, as you're very likely to know, is it stops the lungs being able to do exactly what they're designed to do, and that's to exchange oxygen and carbon dioxide. So they will come in with acute shortness of breath, very rapid breathing, and bluish skin. They're horrible when you see them. Very blue lips and often quite blue skin. A lot of them don't survive. So this will be what their chest X-ray looks like. Right, I said I promised you about pneumothorax, and the reason a pneumothorax is so important is because they're so hard to see. You wouldn't think so. I mean, the blue arrow helps, I have to admit. But actually, the two type of pneumothoraxes, I guess it depends if you're a Latin scholar or not. The two ones that are really hard to see are the very, very small and the very, very big. If it's a medium-sized pneumothorax like this one, it's actually okay to see because, so this is your normal lung over here, and you've got all the lovely lung markings, okay? When I say lung markings, I just mean these white lines, okay? So a very small pneumothorax will usually show up here as a tiny little black line, and you've got to really be aware of it, okay? The next day it might have grown, so that's why you've got to be aware of it. But you often don't see it, and it's slightly easier to see the next day. Okay, and then the really big one is, sorry, now this is a medium-sized one, so you can see this line here. It's quite big, but a really big one will sit down here, sort of along the side of the heart. So all of this whole lung looks the same. This one has this little pocket of lung, so you can see it. It sticks out like a dog's tail, okay? And you can see that line like a silhouette sign. But if it was sitting along here by the side of the heart, you wouldn't be able to see it. Now, if that's the case, this entire lung cavity looks the same density. So unless you're really comparing it, which you should be, because you've learnt the rule of 2, to the other side, you're like, yep, this lung looks right. And then you go over to here and you say, this lung looks right, but it's not even a lung, it's just a hole, okay? But you don't notice that because the whole density is the same, all right? So the little ones are hard to see and the really big ones are hard to see, but everything else looks quite easy because it's black hole next to normal-ish lung. Right, so say what you see, basically with everything, but especially in a chest x-ray. You start off with, this is a PA view chest x-ray, or this is an AP view chest x-ray. And then you might say erect or supine, if it's an AP. If you can see the vertebra behind the heart, you say it's a normal exposure. And you talk about rotation. Like if they're twisted to one side, that's another reason you can't measure the heart, okay? And bony abnormalities come up early. Broken ribs, stuff like that. Quite obvious, usually from major trauma. Can be serious if you've got two or more broken ribs in a row on the same side. Flail chest sort of stuff. Difficulty breathing. Always a good thing. But just a stand like a cracked rib, you know, a cracked rib is treated like a sore rib. Don't cough. Don't sneeze. If you do, it'll be sore. Now go away. Okay. And then you talk about lung fields are clear with normal markings. Or not. Left lung field is clear with normal markings. Right lung field, no visible markings seen. That sort of thing. So it literally goes through this checklist, and it's usually in this order. And then they talk about the heart, so the cardiovascular silhouette. See, like I said, we get paid per word, right? So the heart size is within normal limits, okay? And then they just kind of go into things like the dome of the diaphragm, the costeophrenic and the cardiophrenic angles are visible. Now that's important because if the costeophrenic and the cardiophrenic angles are not visible, it means there's fluid down there. You should see a nice little triangle. And if you can see a round semicircle, it means there's fluid down there. So all of these extra little signs show you a lot more than you think. And then you say that the soft shadow can be like, which just means the tissue, are like the shoulders and the sides of the patient are all within normal limits, or they're not within normal limits. Okay? I think that's it. Yes, it is. I'll go back up one because I hate the black screen. But what time is that?
You did really well. It's just after 8. No, you did fantastically well.
So guys, if there's extra stuff you want to know about, I can add it to this. Or if you have questions now and I can answer them, I will. I don't have all the answers, but I can get them for you.
You just give them a second to get their buttons going.
What's that?
Just give them a second to get their buttons going. It quite often just takes a minute for people to get their questions together. Just say, oh, well, Michelle Smith says thank you. She's got a question, she's ignoring. And Sonia says that was great, thanks.
Oh, you're welcome. Thank you. Appreciate you taking your time in the evening.
No, it's interesting, and some of it's just going over things that you've got an idea about, but just to get a bit
100%
more
aware.
feel.
This was not teaching you guys stuff you didn't know. It's kind of like in January after Christmas when you look at the, you know, you're on Twitter or Instagram or something and you see that, you know, going to the gym and eating slightly less food is probably good for losing weight. It's not something that's going to blow your mind, but having a little reminder every now and then doesn't hurt.
And you've got a whole range of people on here, students as well, like student nursing students, a lot are coming through. So you've got someone there saying they definitely learned a lot. Thanks for the very interesting and entertaining talk. Sticking out like a dog's tail.
Yeah, sorry about that. Normally I can judge the audience, you see, but on a completely blind thing, I thought I don't want someone sitting there with their bottom lip out.
And then someone saying, good to know about the beak signs. So can you please explain scaphoid fractures and why there is a delay in seeing the fracture? Yes,
and this is a really common fracture. So you've got 8 bones in your wrist, right? 8 carpal bones, okay? And the scaphoid is by far the most commonly fractured. Now, if you are a tennis player like Roger Federer or someone like that, and you fell over and you hurt your wrist, he's going to have, probably in this order, he's going to have an X-ray of his wrist, and if they can't see a fracture, he's going to go to MRI, and if they can't see the fracture, he's going to go to nuclear medicine. All right? Now, an X-ray probably costs about $40, an MRI might cost $800, and a nuclear medicine might cost about $600. So that's an awful lot of work for a fractured wrist. Now, if I fall over and break my wrist, I'll have an X-ray, because I don't play tennis to anything like the level that Roger Federer does. Now, the thing about the scaphoid is it's kind of got 3 parts, radiographically anyway. It's got a north pole, a south pole, and a waist. Now, the scaphoid fractures along the waist on about 96% of occasions, all right? What happens is it fractures the blood supply to the bone. So after about a week or 10 days, you've started to have a little bit of avascular necrosis setting in. So one side of the bone, usually the north pole, I've just realized there's a place called the North Pole as well. I've said that so many times and I never realized. Anyway, so normally the North Pole will get a little bit darker than the South Pole. And you'll be able to say that the avascular necrosis, avascular just means there's no blood, and necrosis being death. So bone death due to no blood is creeping into that area. Therefore, we know there's a fracture. By that stage, you'll probably be able to see the fracture as well, because there might be a little bit of shrinkage, and you can send them down to the theatre to get what's usually just like a single screw or a bit of K-wire put in. In that week or 10 days, it's treated like a fracture. So there's no harm done. They just put them in a cast, all right? So they'll go away with a cast, come back, get the cast off, get re-x-rayed. Now, I don't know if that answered your question, so if you could give Catherine the thumbs up, whoever that was. Or
well, they're thinking, we've got more coming in just saying, thank you, clarified so much. That was really good. A lot of people liked your humour. And one says, say a big hello to your sister. She's a friend of mine. That's from Fiona Thomas.
Oh, well, I'll write that down. Hello, Fiona.
And you got the thumbs up. You got a thanks and a thumbs up. So you must have answered their question.
Oh, that's good.
And then I've got Ian's asking, can you please add AVN slide as well?
A what?
An AVN.
Oh, AVM, sure.
AVN, yeah. And I think that's about your. I think you're off the hook. Thank you very much. It's yeah, great start to the year for us. A fantastic webinar.